Alterations in integument, pressure injuries. Pressure injuries are localized areas of tissue necrosis that develop when soft tissue is compressed between a bony prominence and an external surface for a prolonged period of time. However, that prolonged period of time may not be all that long. It can actually be just an hour or two in some clients. The National Pressure Ulcer Advisory Panel prefers the term pressure injuries for what are commonly called bed sores, decubitus ulcers, or pressure ulcers or sores. So once again, pressure injuries will develop when blood flow to an area is reduced as the skin is compressed between a bony prominence and whatever surface the client is lying or sitting on. They're expensive to treat and they result in longer hospital stays, in addition to increasing the likelihood of placement in a long-term care facility, and they increase mortality. So factors that contribute to the development of pressure ulcers or injuries, in addition to immobility, will be shearing forces, chemical irritants such as urine, sedation, and poor nutrition. Pressure injuries can occur within 1 or 2 hours in people that have healthy skin and adequate circulation. To prevent pressure injuries, it's important to identify those clients that will be at risk. There are common tools that can help predict pressure injuries, and that would include the Norton scale and the Braden scale. It's important to reposition the client in bed at least every 2 hours. And some clients, especially the ones that are at higher risk, may require more frequent positioning. They should be positioned so they're not resting on pressure points of the skin. We also need to teach wheelchair clients to shift their weight every 15 minutes if possible. Clients that are not able to do this need to be repositioned at least hourly. Keep the bed linens dry, smooth, and free of wrinkles. Gently cleanse the skin when it's soiled and at regular intervals using warm water and a mild cleansing agent. You should never scrub the skin. Use moisturizers, lubricants, protective films or barriers, and dressings to help reduce friction and shearing. Avoid friction when you're moving clients to help prevent skin damage by using that lift sheet. A lift sheet is exactly what it says. You use the sheet not to pull the client up in bed, but to lift them and pull them up in bed. Use measures that will enhance client mobility, such as trapeze bars. Remember, in bed, keep the head lowered as much as possible because when they're sitting up in bed, they're actually going to be sliding down, creating those shear forces. Special surfaces for the bed or chair can also help reduce pressure, such as egg crate foam mattresses that needs to be a minimum of 2 inches thick. Static air mattresses, alternating air mattresses, gel cushions, fluidized air, or water mattresses can also help. Sheepskin boots can help prevent shearing forces to the feet, and pillows or other devices can also prevent heel pressure. If you look at the picture here, you have a heel boot that has a cutout for the heel to keep the pressure off of the heel. They're using a lift sheet here appropriately by lifting the client to move. This elevated cushion helps keep the heels off of the bed. You also should protect the skin from excessive moisture. So use absorbent pads or briefs for incontinence, and instruct the client and family about risk factors and strategies for preventing pressure injuries. Excessive moisture can lead to skin impairment. Be aware that some items such as rubber rings will actually increase pressure and should not be used to elevate the heels or sacral areas. And we also need to provide appropriate nutrition and hydration. Nutrition would include increasing protein to promote healing, small frequent meals to improve caloric intake, and maybe supplementing vitamins A and C, or even giving zinc to help improve healing. A pressure injury is usually going to begin as erythema, and that's a sign that the area has impaired blood flow. If pressure injuries develop despite all preventive measures, then you need to assess the stage and describe it precisely. Remember, only pressure injuries can be staged. Stage 1, we have erythema. Remember, that's the redness that does not blanch when it's pressed down. It might be red to a dusky blue in color. The shape is usually irregular and can reflect the shape of the object that's creating the pressure. Pain and tenderness might be present with swelling and hardening of the tissue or associated heat. There's little destruction of tissue, and the condition is reversible if the pressure is relieved. Partial thickness skin loss in the epidermis and dermis revealing epithelial tissue is a stage 2. The wound is shallow and can appear blistered, cracked, or abraded, or that means scraped. In fact, serum-filled blisters are stage 2 pressure injuries if it's located over a pressure point. The ulcer might be surrounded by a broad, irregular, and painful reddened area that's warmer than normal to touch. A stage 3 pressure injury is a full thickness skin loss, and this involves damage to the dermis and subcutaneous tissue, and it reveals over 50% granulation tissue. It will appear as a crater-like sore, and it usually has a pretty distinct outer margin. The wound may be infected, and it's usually open with some type of exudate. A stage 4 is a full thickness skin loss with extensive destruction of tissue into the deeper structures, including muscle, tendon, ligament, or bone, and it also will reveal over 50% granulation tissue. These wounds can also be infected with exudate. An unstageable pressure injury is going to be one that has a wound bed that is covered by more than 50% eschar or slough. If it has greater than 50%, it is going to be unstageable. If the slough or eschar were debrided from the wound bed, we do know that it would be at least a stage 3 wound. And then a deep tissue injury, also known as a DTI. This injury is going to be dark purple or dark red in color with intact skin, usually located over a pressure point. It looks like a bruise, but it's not a bruise. An intact serum-filled blister over a pressure point that becomes filled with blood changes from a stage 2 to a DTI when it fills with blood. We do know that if a DTI were to open, it would be at least a stage 3 pressure injury. However, many DTIs will resolve without ever opening. The PUSH tool was developed by the National Pressure Ulcer Advisory Panel as a measurement tool to help identify improvement or deterioration in pressure injuries. On a weekly basis, we measured wounds. We would get the length of the wound multiplied by the width of the wound, and the product would be matched up on this PUSH tool with the appropriate score. The amount of exudate is matched up with the correct score, and then finally the tissue type is scored. Those 3 scores are then totaled to help determine what the PUSH score is. So we do this on a week-by-week basis, and we can determine if the wound is improving or deteriorating, and we have a measurable tool to do this with. So the first step in treating pressure injuries is going to continue all preventative measures. Wound healing will be enhanced when the wound and the surrounding tissues are offloaded to help improve circulation to the wound. Supportive care will consist of measures to treat comorbidities or other client illnesses such as diabetes or heart disease. Nutrition has to be assessed to assure adequate intake, especially of protein, and understand supplements may be required. The wound should be cleansed with mild soap and water or normal saline. And we need to consider avoiding the use of pastes, creams, ointments, and powders because sometimes they can promote infections in the wound. However, an ointment such as zinc oxide can be highly effective in stage 2, and some small stage 3 pressure injuries. You should always avoid the use of alcohol, antiseptics, disinfectants, topical or oral antibiotics, and massage unless the wound is exhibiting signs of infection. The most effective dressing will provide a moist environment and maintain a temperature close to body temperature. So if you have to remove that dressing frequently, you're removing that body temperature at the wound site, so you're slowing down healing. So you need a wound dressing that's going to be able to stay in place for an extended length of time. The goal of debridement of slough or eschar would be to reach healthy pink granulation tissue, and if it bleeds, that means you've reached the good tissue. In the past, wet to dry dressings were used for debridement, but it actually traumatizes the skin when the dressing's removed, and it removes not only the necrotic tissue, but also the good tissue. However, there's a lot of physicians out there that continue to order this dressing. Debridement can be accomplished chemically. Santyl is the only authorized FDA chemical debridement. It's very slow, but it is effective. It can be done biologically with a medical grade maggot or with sharp debridement, which is accomplished with sharp instruments like scissors, a curette, or a scalpel. And wounds may require serial debridements.